Today we're going to present a case of a lateral discoid meniscus with saucerization and subsequently needed repair. This is a young 13-year-old patient with continued pain. They had failed non-operative treatment and found to have a tear of their lateral discoid meniscus. Again, you can see here there's concern for lack of posterior horn attachment. The tear is not visible at this portion. We begin with saucerization. This requires a sequential order of a shaver and biter. Again, the hardest portion of this is to get the initial saucerization started. Using a series of biters and a shaver, we continue to make progress towards adjusting the meniscus to its roughly normal peripheral length of roughly 7 to 9 millimeters. As we continue to make our way into saucerizing the meniscus, you can see here there's significant mobility of this meniscus. In addition, you can see that there is a inflamed and uncontained tear of the undersurface. You can see here there is a complete lack of meniscal root attachment on both the posterior and anterior meniscofemoral ligaments of the posterior horn. Again, we continue to use a series of shavers and biters. Given this tear in the posterior horn was not contained, the decision was made to further saucerize this rather than perform a direct repair. And again, we are still not at the level of debulking we will need to have a normal width meniscus. We continue to work on the anterior and central portions. Here you can see we've appropriately saucerized it. We still have a normal amount of meniscus remaining. This is more than 50% of instability, and we're concerned we have a Risberg type with a posterior root variant. Again, the biggest issue in this situation is once you've saucerized the meniscus, the instability is concerning, and in this case we decided to perform a meniscal root repair to reattach the missing anatomy. You can see there's significant mobility of the meniscus, and this is a concern for future issues. If this is not addressed, the patient will likely fail and eventually need a meniscus transplant. Here we prepare the area for the transtibial drilling. We use a curved 1-pass and mini tape. We place a locking suture which has the highest biomechanical strength. In most cases we use 2 passes. Again, the care here is to not be too close to the posterior horn of the root as it can pull out, and you want a good bite in the periphery. Again, this is a second locking suture, which recent studies have shown is the highest biomechanical strength. We use our Smith & Nephew meniscal root guide. We place a transtibial tunnel. Again, there's a metal sleeve which we pass a passing device through. We have a passport in the lateral cannula, which we pass all these sutures through and prevent any suture tangling. Following this is sequentially tightened. We secure this with a anchor. Here we're testing mobility. There is still anterior posterior mobility. So once we've secured the root, we will do a all inside posterior horn fixation. Here you can see there's no mobility. We brought the root over and restabilized the meniscus with hopes that this will scar down. Following this, we use an all inside device. In this case, we'll perform a vertical mattress throughout the meniscus itself to compress any intrasubstance tearing and to secure the entire meniscus back to the capsule. This is tensioned and cut. Again, this is a process of continuing to check the meniscus for any further instability if needed. In this situation, there was no lateral instability, but there was anterior instability as well that occurred. So we performed an inside-out repair using 2 spinal needles, PDS sutures, and a suture tape. As you can see, we pass this through the periphery in both instances. We have 2 different PDS sutures, and we pull these through with suture tape and secure the anterior horn. Following, you can see us probing. There's no further instability of the meniscus, and we've reapproximated the normal anatomy of the lateral meniscus. Again, careful attention is made to see if any further fixation is needed in these less common types. Here we perform microfracture of the notch, as recent data has demonstrated improved meniscal healing.